So this week, this week's lecture is going to be on valvular heart disease. Uh, we should be able to complete aortic stenosis, but the full spectrum of what we're going to do on the valvular heart disease, well, the aortic stenosis, aortic insufficiency, mitral stenosis, and mitral regurgitation. So those are the topics we're going to cover. Uh, just a little background information on valvular heart disease. So when we talk about valvular heart disease, we're talking about disease that affect the heart valves. Okay, and the four valves that we're going to look at is the aortic valve, the pulmonic valve, the mitral valve, and the tricuspid valve. The reason why we separate them as I did, so in this session we're going to do aortic and mitral valves. That's because the tricuspid and the pulmonic valve we're gonna do those on the when we do right heart. So you see where we have lectures on right heart. We'll do the right heart valves when we do the right heart. So we're going to do everything related to the right heart or the right side of the heart. And that includes the tricuspid and the pulmonic valves. So in this valvular heart disease session, we're just going to concentrate on the left-sided heart valves, so the aortic valve and the mitral valve. So valvular heart disease, uh, of course, affects the aortic, mitral, tricuspid, and pulmonic valves, all the valves in the heart. It's extremely common. So this is one of the what we call the bread and butter topic of echo. A lot of your patients going to come in and they're going to have valvular heart disease. So you have to have a good appreciation for this. Patients going to come in with symptoms. They'll have signs and symptoms of if the valvular heart disease is significant. They're going to have signs and symptoms related to this. And some of the signs, that is things that you can elicit, things that you can see on the patient. Leg edema, the legs are swollen. Ascites is fluid in the abdominal cavity. So they will have a big belly because there's fluid in the abdominal cavity. So the belly will appear fairly big. And then because it's a valvular problem, when you listen to the heart, they'll have a murmur. So when you listen to the heart, if the patient has stenosis, then you'll hear the murmur related to stenosis. If it's regurgitation, then you'll hear the murmur related to regurgitation. If the valvular heart disease, say it's mitral regurgitation, then the left atrium is going to get enlarged, the left ventricle is going to get enlarged. So when you palpate, so when you put your hand on the patient's chest and feel for the size of the heart, it's going to be enlarged. I would call that cardiomegaly. So cardiomegaly means an enlargement of the heart. And if the patient have pulmonary hypertension, or if they have significant tricuspid regurgitation or significant problem with the right side of the heart, you can get what we call hepatomegaly. That is, the liver will be enlarged. And you can these are stuff that you can palpate. So when we say palpate, you put your hand down and you can feel, then you'll feel that the liver is enlarged. So these are signs that the patient have significant valvular heart disease. Okay, so cardiomegaly, enlarged heart, hepatomegaly, enlarged liver. Because remember, the inferior vena cava passes through the liver, and the inferior vena cava gives off the hepatic vein. So if you have blood backing up into the inferior vena cava, it's going to back up also into the hepatic vein, and it's going to cause the liver to be engorged with blood. So Not only will you get hepatomegaly, which is enlargement of the liver, but it will be tender. Okay, so the liver will be, when you palpate the right lower quadrant in the abdominal cavity, the liver will be enlarged and tender. And you can get tachycardia, that is rapid heartbeat, as a result of these valvular problem. And then when you listen again, you commonly get what we call a third heart sound, uh, so-called S3, which suggests that the patient is in heart failure. So the third heart sound, or S3, is suggestive that the patient is in heart failure. And sometimes they'll also have a fourth heart sound. Okay, so those are some of the signs that you will get um, related to valvular problems. So what are some of the symptoms now? So symptoms is what the patient's going to tell you that they're experiencing. They'll tell you that they're short of breath. So it will start with shortness of breath with exertion. When they walk, they'll be short of breath. Then when it gets more severe, they'll have shortness of breath when they're at rest, when they're not doing anything. Fatigue, because you're going to get decreased cardiac output, decreased stroke volume, decreased cardiac output. The patient, so the muscle is going to be devoid. The muscle is not going to get sufficient blood flow. So there'll be fatigue and weak and then dizzy, not enough blood flow to the brain. And sometimes they can pass out. So aortic stenosis and sometimes mitral stenosis, because there's not enough blood getting out of the heart, these patients can pass out. Okay, so one of the common symptoms of aortic stenosis is syncope, patient passing out because enough blood is not getting out of the heart. And then chest pain, and that is because what we call the subendocardial region of the heart um, is not getting sufficient blood flow. So the patient have ischemic chest pain, chest pain. Hemoptysis, especially with mitral stenosis, because the mitral valve is not opening, the pressure and the size of the left atrium increases, so the blood flow back up all the way to the lungs. So that can destroy a lot of the capillaries in the lungs, so the patient will cough up blood. So hemoptysis is coughing up blood. Okay, and then especially patients with mitral stenosis, they can develop atrial fibrillation, and they will tell you that they have these palpitations. Okay, so palpitation is the patient tell you they feel the heart fluttering. So we went over the signs: leg edema, ascites. Remember, ascites is fluid in the abdominal cavity. Patients will have a big belly. Leg edema is swelling of the legs. Murmurs, what you listen to. Cardiomegaly, enlarged heart. You can palpate that. Hepatomegaly, and of course, tender hepatomegaly. The liver is enlarged. And because the liver is enlarged, it stretches the capsule that the liver is in, and the patient will tell you that they have pain. And then when you press down, they'll jump because it's tender. Tachycardia, increased heart rate, third heart sound, fourth heart sound. Okay, so what are some of the causes of these valvular heart disease? One of the big causes, rheumatic heart disease. And this is extremely common in the Caribbean and other developing countries. So rheumatic heart disease, okay? Uh, what usually happens as a kid, the patient will get a strep throat or strep infection, and that because there's a immune reaction. That immune reaction will damage the heart valves, and initially they'll get inflammation. Okay, they'll get inflammation, but they're not gonna develop the full-blown valvular heart disease until 5, 10, 15 years later. Okay, so they'll get the rheumatic fever as a kid. They have joint pains, fever, sore throat, that type of thing. And they'll have the inflammation because of the immune reaction, but it's not until long after then they're going to present with rheumatic heart disease. Okay, so it's important to remember that. They usually don't present with rheumatic heart disease as a child. Okay, I mean, you can get rheumatic myocarditis. So if they present as a child, then it's really bad. They have a myocarditis, and that can be really, really bad. But the usual scenario is they'll have these strep infection as a kid, and then 10, 15 years later, then they'll present with the classic rheumatic heart disease, which is mitral stenosis, mitral regurgitation, or aortic regurgitation or stenosis. And sometimes it can involve the right-sided valves as well. So under valvular heart disease, you have congenital heart disease, okay, and congenital valvular problems. One of the most common congenital valvular problem is a bicuspid aortic valve. Remember, in our teaching, we talk about a tricuspid aortic valve. That's the normal aortic valve. It's supposed to be tricuspid. And a tricuspid aortic valve is important because it allows laminar flow, that nice flow that you're supposed to get. When you have a bicuspid aortic valve, the flow is not laminar, it's turbulent. So it's damaged the valve, and the valve can become stenotic and regurgitant. So that is the problem with these bicuspid aortic valve. You can also have a unicuspid aortic valve or a quadricuspid aortic valve. So it may have only one cusp, or may have four cusps, or even more. Infective endocarditis. This is when you get infection involving the heart valves, and these infections usually produce a tumor-like material on the valve, which prevent the normal functioning of the valve. Remember, the valve is supposed to close and allow blood flow in just one direction, that type of thing. But if you have endocarditis and a vegetation, so you'll hear we talk about vegetation, it's infected material that that is on the valve and prevent proper functioning of the valve. So the patient's going to present with either commonly regurgitation, because the valve is not going to close properly. So they'll present with regurgitation. Occasionally, the vegetation can obstruct the valve, and they can present with stenosis. But the more common presentation is regurgitation. And they're going to have all the signs and symptoms of infection: fever, malaise, lethargy, and white cell count. So they'll have all the features of infection. And then when you listen to the heart, because the valve is not closing properly, you'll hear a murmur. We usually talk about a new murmur or a change in murmur, because the infected material, i.e. the vegetation, is on the valve, preventing proper function of the valve. Trauma. So trauma is another important cause of valvular heart disease, especially patient driving, involved in a motor vehicle accident. The steering wheel hit the chest. Sometimes you'll have rupture of the cords. You have rupture of the cords of the tricuspid valve, and the patients will have tricuspid regurgitation. We see a lot of those. Okay, so trauma can do it. Tumor. If you are, a myxoma. So a myxoma is a tumor in the heart, and it's the usual location is the atrial septum. So the tumor is attached to the atrial septum, and when the mitral valve opens, it tries to get out of the left atrium, and it can present like mitral stenosis and cause mitral regurgitation. So tumor can also present as valvular heart disease. Connective tissue disease, such as lupus, Okay, and then myxomatous degeneration. So myxomatous degeneration and mitral valve prolapse is sort of synonymous. So patients mitral valve prolapse is extremely common. So extremely common. So you'll see patients who have mitral valve prolapse and mitral regurgitation. So how do you treat these patients with valvular heart disease? So if it's not very bad, you can just use medication. Um, you know, if it's beyond treatment, the patient comes in too late, then it's probably just medical management. But majority of the patients who have valvular problem, you can do something for them. So you can either repair the valve or replace the valve. Okay, so you know because if you don't, the patient's going to be symptomatic, shortness of breath, fatigue, malaise. So you can, if you can repair it, and the valve that lends itself readily to repair is the mitral valve. So the mitral valve, if it's repairable, you repair it. Sometimes the tricuspid valve, especially, patients with a ruptured cord from traumatic chest injury, you can repair the valve. But majority of the time, you're going to have to replace the valve, remove it. And when you replace the valve, you can either use what we call a bioprosthesis. So bioprosthesis is using tissue, whether it's from humans or it's from animal source. So you can use, or if you can do mechanical prosthesis, a mechanical valve, a metallic valve. So those are the approach. All right, so we're going to move into aortic stenosis. So in our basic lectures, we identify the aortic valve. We know what the aortic valve is supposed to look like. It's supposed to have three cusps. It's supposed to open to a certain size, but sometimes the aortic valve can be stenotic, not opening properly. Okay, so the aortic valve is supposed to open a nice size. We talk about the normal size of the aortic valve being 3 to 5 centimeters squared. Okay, that is the normal size. If it's restricted in its opening, then that's what we call aortic stenosis. We don't usually talk about aortic stenosis until the valve area is less than 2 centimeters squared. So normal size 3 to 5 centimeters squared, but we don't talk about stenosis, aortic stenosis, until the valve area is less than 2 centimeters squared. Okay, so in aortic stenosis, the opening of the aortic valve is restricted. It's not opening properly. So stenosis in anything means it's not opening properly. So how these patients going to present? So remember what the heart does. The heart contract and it relaxes, contract, relaxes. When the left ventricle contracts, it's going to push blood out of the left ventricular flow tract across the aortic valve into the aorta, and that's how the body gets blood. That's how the body gets blood. All of the body gets blood by blood flowing out of the left ventricle across the left ventricular flow tract, across the aortic valve into the aorta. So if you have aortic stenosis, the opening of the aortic valve is narrowed for whatever reason. The patient's going to have shortness of breath when they exert themselves. Because when they exert themselves, what's going to happen? You're going to have tachycardia, and the body is going to try to increase blood flow across the aortic valve. It just can't happen. So blood is going to back up into the left ventricular cavity, it's going to back up into the left atrium, and it's going to back up into the lungs. And then the patient is going to have shortness of breath. So that's why they have dyspnea, means shortness of breath. So shortness of breath and exertion, that's how it usually starts. And remember, we talk about syncope. One of the presenting uh, signs and symptoms of significant aortic stenosis is syncope, patient passing out. So Usually, if the patient have aortic stenosis and they pass out, that's an indication that the valve needs to be replaced. Okay? And more dramatic, if they present with sudden cardiac death, then if they're resuscitated, then that's also an indication that the valve needs to be replaced. Okay? Chest pain. With aortic stenosis, chest pain. And that's because they get subendocardial ischemia, especially if the left ventricle, if the muscle is thickened. Because just imagine, the LV is pumping and it's trying to get blood across the aortic valve. But because the aortic valve is narrowed, it has to increase its effort. So over time, the left ventricle, the muscle, the myocardium gets thickened and it outstrips the blood supply somewhat. So the subendocardial area can have decreased blood flow, which we call ischemia. So the patient can present with chest pain because the subendocardium, just below the endocardium and below, is not getting sufficient blood flow, blood supply. So they'll present with chest pain. So those of you guys who read literatures, you'll see that the important uh, signs and symptoms when someone has significant aortic stenosis is chest pain, shortness of breath, and syncope. Those are the three big ones. When the patient have these symptoms, it's time to replace the valve. Okay, and then when you listen to the patient chest, you get what we call an ejection systolic murmur at the base radiating to the neck. So this is classic because you're going to get turbulence when the left ventricle contracts and it's pushing blood across the aortic valve. You're going to get turbulence, and you hear that. So it's a systolic phenomenon. So we talk about an ejection systolic murmur. It's a diamond-shaped murmur. It goes up and it comes down. Okay, radiating to the neck. So that's classic. So some of the causes of aortic stenosis, and you have to know what's going to cause aortic stenosis. One of the big cause is aging. The aging population will present with aortic stenosis, whether they like it, yes or no, because the aortic valve over time degenerates. So we call it senile degeneration. It degenerates and it becomes thickened and calcified. And because it becomes thickened and calcified, it doesn't open properly. And it's very, very common to see someone at age 90 have no medical problem but present with significant aortic stenosis. And that was one of the reasons why we developed TAVR, trans-aortic valve replacement. Instead of opening the patient's chest and putting in a new aortic valve, we can do it percutaneously, go through the blood vessels. We can go through the femoral artery and go up and put the aortic valve like that. Because if you open a 90-year-old patient chest, the mere fact that you open the chest, their mortality rate is going to be like 50%. Okay? So they usually don't survive the surgery. But if you do it through the groin, they do very well. So we are commonly doing TAVR, trans-aortic valve replacement, for these 90-year-old patients who present with aortic stenosis. Another big cause for aortic stenosis is bicuspid aortic valve. So remember, the normal aortic valve is supposed to have 3 leaflets. If it has 2 leaflets, then you're going to lose your laminar flow. You're going to get turbulence. Turbulence over time is going to cause the valve to become thickened and restricted. So if you see someone with significant aortic stenosis, age 40, 50, it's more than likely bicuspid aortic valve because they're not going to have age-related aortic stenosis, senile degeneration. Usually get that in patients 80 and 90. Okay, so younger individual 40, 50% with significant aortic stenosis, probably bicuspid aortic valve. Acute rheumatic fever, uh, you know, that can do. It's not very common for acute rheumatic fever to give aortic stenosis, but it does occur. Endocarditis, remember the vegetation can obstruct the valve and the patient can present with aortic stenosis. It's okay. So this is your parasternal long axis view, and this is the view that you know you should start with, and you can quickly see that this patient have a problem with the aortic valve. If you look at the aortic valve, it's thickened, and this is a systolic frame, and the valve is not opening to its full extent. So right away, by just doing the study, you have an inclination that this patient have aortic stenosis. There are more stuff you have to do to confirm your suspicion, but just looking at it, it looks as if they have aortic stenosis. Thicken aortic leaflets, it's not opening to its full extent. Okay? So again, this is your parasternal long axis view. Your chest wall is right there. Your RV wall, this is your RV cavity. Septum, ventricular septum. This is the LV cavity. Posterior wall here. The pericardium is below there. The mitral valve, anterior leaflet, posterior leaflet. This is your left atrium and your aortic valve with your ascending aorta. All right, so you have an inclination that the patient have aortic stenosis. So what you're going to do? So you're going to just go on with your regular study, okay? But there are certain measurements that you have to get, okay? And we're going to go over those measurements. One of the measurements you're going to get is the left ventricular outflow tract diameter. So you have to know how to do these measurements. It's important. The LVOT diameter measurement is done in systole, and it's just before the aortic valve, and you measure from the tissue blood plane to your tissue blood plane just in front of the aortic valve, LVOT diameter. Okay. This is a short axis view at the level of the aorta. But because the aortic valve is thickened and calcified, you don't see it properly. But that's the aortic valve right there. So with the M mode, I mean, I know we have not done M mode with some of you guys, but the M mode will also tip you off that there is aortic stenosis. So when you look at your M mode, so on top you have your two-dimensional echo, okay, and you have your cursor crosses right here. So the structures that the cursor crosses: the chest wall, the RV wall, RV cavity, the aortic valve, the left atrium, and the left atrial wall. So these are the same structures that you're looking at down here. The chest wall is on top. Below the chest wall, you have the RV wall. Then the next layer is the RV cavity. So blood with your M mode looks black, as it does with your 2D. So this is the RV cavity. Okay. Below the RV cavity is the aortic wall, because that's the next structure the cursor crosses. So this is the aortic wall. So this is this portion of the aortic wall, and then the lower portion of the aortic wall is right there. Inside the aortic wall is the aortic valve. So this structure right here, inside the aortic wall, is the aortic valve. And again, everything is gated in echo. What we mean by that, you have your ECG on top. Everything is either systole or diastole. The aortic valve opens in systole, and it opens in systole in this nice box-like shape structure. It closes in diastole, which is this line, and then again it opens in systole, box-like shape structure, and it closes in diastole. This is the lower portion of the aortic wall. And this is the left atrial cavity. Okay, so when someone have aortic stenosis and you have your cursor crossing through the same structures as over here, then the chest wall is on top, the RV wall is below, the RV cavity is right here. Then you have the aortic wall. Inside the aortic wall, you have the aortic valve. And when you look, you can see that the aortic valve is thickened. So this line, which, if you look at there, it's not very thickened, but over here, it's thickened, very thickened. And then when we talk about cusp separation, the separation of the cusp, if you were to measure it, you see that it's decreased. It's decreased. Okay? So your M mode can also tip you off that you're dealing with aortic stenosis. And of course, we have separate lectures to go over M mode, so we'll you'll get full understanding of M mode at some point in time. All right, so 5-chamber view is important. Not only because we can see the aortic valve in the 5-chamber view, but because you need to get your left ventricular outflow tract TVI. Okay? So you're going to get, so in your 5-chamber view, your cursor is right there, and the point of interest is a little way from the aortic valve. It shouldn't be in the aortic valve. It should be a little distance away. And then you need to get your nice laminar flow in the LVOT, and you're going to trace that to get the LVOT TVI or VTI, velocity time integral. You're going to plane that. Okay? Remember when we did hemodynamics, we developed a number of concepts. One of the concepts that we developed was stroke volume. And when we talk about stroke volume, it's the volume of blood that the ventricles pump out per beat. And if you remember, that is equal to 0.785 times D squared times VTI. So just for recapping purpose, your stroke volume is equal to 0.785 times D squared times VTI. Okay, so this is what stroke volume. So you can calculate the stroke volume using the echo measurements. So, and I show you how we develop this equation. We're not going to do that again. But D squared is when you do the diameter, the left ventricular flow tract that I just showed. So that is the D we're talking about, the diameter. And then the VTI, this is the VTI we're talking about. Okay, so you put your cursor, 5-chamber view, sample volume is right there, and you just turn your Doppler on. So this is a P Doppler measurement, okay? And you just traces around it, and the machine will give you VTI, velocity time integral. So if you put everything in your equation, you'll get your stroke volume. And then cardiac output is just stroke volume times the heart rate. But we also develop another concept using the continuity equation. And the concept that we developed was the flow in one area of the heart is equal to the flow in the next area. And we look specifically at the aortic valve because the flow across the left ventricular flow tract is going to equal to the flow across the aortic valve. So the flow across the left ventricular flow tract is equal to the flow across the aortic valve. So again, if you remember, flow is equal to the cross-sectional area times the TVI. So if we use the aortic valve, the area of A times the VTI across the aortic valve. So that's the flow across the aortic valve, right? Using the continuity equation. Okay, this is a high. Don't worry about it. You know, in some place that's a high. Don't worry. All right, so the flow across the aortic valve, which is equal to the area times the VTI, that's equal to the flow across the left ventricular flow tract because there's no leak. So the flow going across the left ventricular flow tract is going to equal to the flow across the aortic valve. So again, the flow across the left ventricular flow tract is equal to the area of the left ventricular flow tract. And if we call the area of the left ventricular flow tract, call that L. Call that area L for whatever reason. And the VTI across the left ventricular flow tract, we can call that VTI. Okay, I said that's high in some, wow, this high is getting away. Anyway, so this is a high. Okay, don't worry about it. It's a high. So let's call this VTIL because it's the VTI across the left ventricular flow tract. So the continuity equation states that the flow across the aortic valve is equal to the flow across the left ventricular flow tract. We can calculate the flow across the left ventricular flow tract, which is this right here, okay? Right up here, flow across the left ventricular flow tract. So the only thing that we don't know usually is the aortic valve area. So if we rearrange our equation, we can calculate the aortic valve area using our hemodynamic principle that I spent so many hours discussing with you guys in the last few lectures. So the aortic valve area is going to equal to the flow across the left ventricular flow tract, which is the area. All right, let me just write down. Flow across the left ventricular flow tract okay, and this is high in some place. All right, so divided by the VTI across the aortic valve. So this VTI is VTIL across the left ventricular flow tract. So You need to know this formula. You need to know this formula. But the area of the LVOT times the VTI of the LVOT is equal to this. So it's equal to point, that's a point, 7, 8, 5. All right, let me put this as a point. Okay, that's a point. Times d squared times the VTI across the left ventricular flow tract. This is VTIL across the left ventricular flow tract divided by the VTI across the aortic valve, velocity time integral. Okay, so if you're woken at 3 a.m. in the morning, you should be able to recite this formula. Okay, tremendous amount of patients have aortic stenosis, and you have to be able to calculate the aortic valve area. Okay, so if you're woken at 3 a.m. in the morning, you should be able to recite the formula. Aortic valve area is equal to 0.785 times d squared times the VTI across the left ventricular flow tract divided by the VTI across the aortic valve. So again, coming back to this point, 5-chamber view, cursor is right there, sample volume is right here, and you get your LVOT VTI. It's done with PW. Okay? All right. So the next step, okay, the next step is to get the VTI across the aortic valve. Okay? All right. So you put so again, your 2D echo is on top, cursor, sample volume. Now you put your sample volume in the aortic valve because you want the flow across the aortic valve now. So you push it lower down into the aortic valve. And you're going to use CW now because you're talking about larger velocity. You're talking about velocity, sometime in the order of 4 meters per second. So you cannot use PW. So you use CW and you get this nice envelope of aortic stenosis. And you just plane the border and you get your VTI. And this is VTI across the aortic valve. This is VTI across the aortic valve. Okay? Just give me 1 second. Okay, so this is the VTI across the aortic valve. So you have all the stuff you need now to plug in your equation and get your aortic valve area. But if you note clearly, when you trace when you do the VTI across the aortic valve, you're going to get a peak gradient. So it's going to give you the maximum velocity, of course, and using the modified Bernoulli equation for V squared, that's your peak gradient, and it also gives you a mean gradient. Okay, so these are very important information that you're gonna get. So you get a peak gradient and you get a mean gradient. Very important information. So another important, because we're using Doppler and as you remember from your Doppler lecture, the angle theater is very important when you're doing Doppler. The larger the angle, the lower the velocity. So you want to get your ultrasound beam as parallel to the moving structure as possible. You want to get that theta close to zero. Remember, the cosine of 0 is 1, and the cosine of 90 is 0. So you want to get that angle theta close to 0. When you're doing anything that involves evaluation of velocity, you have to use multiple windows, because you want to get the maximum velocity, especially when you're calculating valve area. If you don't, you're going to have tremendous amount of errors. Okay, you're going to have tremendous amount of errors, and you can't you want to send someone to surgery. You don't want to use faulty information. Okay, you don't want the surgeon to open the patient's chest and then the valve is wide open. You will never be able to practice your craft again because you didn't calculate the things properly. So multiple windows, because you want to get the ultrasound beam as parallel to the blood flow as possible. All right. So in this case, it's the same patient. Here you get a velocity of a peak velocity 2.72. Same patient, and because you use a different window, velocity of 1.73. So that is the reason you have to use multiple windows. You want to get that maximum velocity. And then this is the same patient using PDOF. So the PDOF is the imageless probe or the pencil probe. This is a little tiny, if you look at the echo machine, it comes, usually have these little tiny probe that you can get into your intercostal space and you can move it around. In a lot of cases, this will give you the maximum velocity. So you should use your pencil probe, okay? And in this case, use your pencil probe. It's an imageless probe, okay? You don't have any image, okay? So it's a blind, not really, well, it's a relatively blind. You have to know what you're doing. So this gives you a peak velocity of 3.78 meters per second. So much different with a mean gradient of 61. So if it's not done properly, you're going to do the patient a grave injustice. So multiple windows, should use your PDOF probe. You want to get the maximum velocity. And okay, so we showed you how we develop the equation. The flow across the aortic valve is equal to the flow across the left ventricular flow tract. There is no leak in the heart. Okay, so the flow across the aortic valve is equal to the flow across the left ventricular flow tract. Rearranging your equation, okay, then you get that the flow across the aortic valve is equal to the flow across the LVOT divided by this is supposed to be the TVI across the aortic valve. So this is supposed to be A. Okay. Again, when you simplify everything, remember area is pi r squared. It's circular. Pi is 3.14. When you simplify everything, you get this. When you plug it in the equation, you get this. This is what we showed you right there. So 3m, you have to recite. If you can't recite it at 3m, I mean, I'm not talking about a hour, half that you get up. I'm talking as soon as someone wake you up. If you can't recite this, then you have major problems. So the area across the aortic valve, 0.785 times d squared times the TVI across the left ventricular flow tract divided by the TVI across the aortic valve. Remember what D is, and then these TVIs. Okay, so in order to calculate your aortic valve area, you have to look at the parasternal long axis, the 5-chamber view, but you want to get your aortic valve TVI and mean and maximum gradient by looking at your apical 5-chamber view, 3-chamber view, right parasternal view, suprasternal notch view, and more importantly, use the Pensa probe at the apex. Okay? Now, we went through all of that for us to classify aortic stenosis. And just like everything else, aortic stenosis, you have mild, moderate, and severe. Mild, moderate, and severe. So let's start with severe. What categorize severe aortic stenosis? Again, remember we do the velocity across the aortic valve using C doubler, and if that velocity is more than 4 meters per second, the aortic stenosis is severe. We do remember when you do your VTI across the aortic valve, it gives you a mean and a maximum gradient. We don't use the maximum gradient, we use the mean gradient. If the mean gradient is greater than 40 millimeters mercury, it's severe aortic stenosis. Okay? Mean gradient greater than 40 suggests severe aortic stenosis. If we use our continuity equation, this one that you have to remember at 3am, if you use that and the aortic valve area is less than 1 centimeter squared, it is severe. If you're going to index it, and remember, when you index anything, you divide it by the body surface area. And if the index comes out to be less than 0.6 centimeters squared, then it's severe aortic stenosis. And then we talk about a velocity ratio. What that is if you're doing a study and it is very suboptimal, poor study, and you cannot calculate your D, so when you're in the parasternal long axis view, you can't see clearly to get your D, then if you can just do the VTI across the left ventricular flow tract and the VTI across the aortic valve, and if that ratio is less than 0.25, then it's severe aortic stenosis. Okay? All right, so we'll move from severe to mild. What constitutes someone with a mild aortic stenosis? So that same the velocity across the aortic valve using C doubler, if it's between 2.6 to 2.5 meters per second, then it's mild. If that mean gradient is less than 20, then it's mild. If the aortic valve area is greater than 1.5 centimeters squared, then it's mild. If you index it and it's greater than 0.85, then it's mild. And that velocity ratio that I just showed you, okay, using the VTI across the LVOT, VTI across the aortic valve, if it's greater than 0.5, then it's mild. Anything that falls in between these two extremes is moderate. Okay? So once you know mild and severe, then you can figure out what's moderate. So we have a category we call aortic sclerosis. So this is when the aortic valve is thickened and it's calcified. So if the aortic valve is thickened and calcified, but when you look at the velocity, if the velocity is less than 2.5 meters per second, then that's what we call aortic sclerosis. That's aortic sclerosis. Okay? So again, you have to know what is severe. Okay? Because if the patient is symptomatic and have severe aortic stenosis, you're going to send these patients to surgery. Okay? So the velocity greater than 4 meters per second, mean gradient greater than 40 millimeters mercury, valve area less than 1 centimeter squared, or if you index it and it's less than 0.6, or if you do a velocity ratio and it's less than 0.25. And then for the mile, you're talking about the velocity between 2.6 and 2.9 meters per second, mean gradient less than 20, valve area greater than 1.5 centimeters squared, and then if you index the valve area and it's greater than 0.85, then it's mild, or the velocity ratio greater than 0.5. So these are the current American College of Cardiology and American Heart Association guidelines, and the European Society of Cardiology as well. So this is what you need to know. All right, so we're gonna conclude aortic stenosis here.